So today we'll be talking about the ward management of neurosurgical patients. In particular, this video is probably aimed at junior residents, interns, just in sort of looking at some of the common pathologies that we encounter in neurosurgery and what a day-to-day management of some of the patients would be like. So just general tips. In terms of sort of basic tasks, in terms of prescribing fluids and analgesias, there's a few things that we have to be careful of, in particular about neurosurgical patients. So, for example, for fluids, in regards to dextrose, we do try to avoid it because we find that it can alter the plasma osmolality. And when we decrease the sodium, the concentration of it, it can actually increase intracranial swelling, and that can be a huge problem whenever we have brain pathology. So we find that whenever we are prescribing fluids, we do tend to stick with normal saline, 0.9%. And generally we can prescribe more than a liter of normal saline in 24 hours, but you just have to be careful with monitoring the electrolytes on a daily basis, or usually on a daily basis. In regards to neurosurgical patients, they are placed at a higher risk of electrolyte abnormalities. So we find that there are conditions such as SIADH and DI, and that will depend on the types of intracranial pathologies that they have. In regards to prescribing pain relief, we do try to avoid NSAIDs like Nurofen or any of the anti-inflammatories because it can alter platelet activity. And when we alter platelet activity, we're worried about the increased risk of bleeding. And then whenever we're worried about someone's level of consciousness, we have to be careful of the types of pain relief that we're prescribing because we don't want to mask a decrease in their level of consciousness that's due to a brain pathology rather than the medications. And we always try to ensure that bleeding is minimized. So we do check on platelet counts and coagulation factors quite often. So we start with one of our most common things that we encounter, cerebral tumors or brain tumors. So here there is a brainstem tumor that we can see on the right-hand side as sort of delineated by this image. You can see a little bit of swelling that's associated with this lesion, and there seems to be some mass effect that's pushing things across to the opposite side. So whenever we find these patients usually come in with sort of progressive history of symptoms that have been sort of sometimes slowly, sometimes quickly developing. And some of these symptoms can benefit from steroids because they can reduce the swelling. Whenever these patients do deteriorate suddenly, they can benefit from further steroids as well as like a stat dose. But often they would also need quite urgent imaging to see if there's anything that has changed in terms of swelling or shift that would warrant a more urgent operation. Most people should be weaned off their steroids, so we should try to get rid of steroids because they do have a lot of side effects. Or at least we try to wean it to a very low dose until they see either their radiation or their medical oncologist. So things like psychosis, intracranial, interspinal sepsis can be quite significant side effects. And whenever we also do prescribe steroids, make sure that you're prescribing a gastric or GI protection. So pantoprazole is usually something that I give with steroids. So whenever we think about tumors, in regards to when they get admitted, we should always try to work them up to see if there's any other places where it could have come from. So full blood count or their blood markers, CT staging. So we get a CT scan of their chest, abdomen, pelvis to see if there's any other areas that could be more easily identifiable or gives us an idea of what this tumor could be. Just because we find things outside of the brain doesn't mean that an operation is not needed, because sometimes an operation will still be needed if it's producing a lot of significant mass effect or symptoms, and whether that tumor is quite easily accessible in the brain. We always get an MRI stealth scan, ideally before an operation, especially when we have time on our hands, because it gives us a great detail and also is used during the operation as a GPS system. So whenever we think about tumors, we try to make a decision of, are we going to just do a biopsy? So like that first image, so a stereotactic needle biopsy, we're just taking a sample to try to figure out what it is. If it's, or we could do a debulking, so try to take as much tumor as possible, but as safely as possible. Or resection, so trying to take the entirety of the tumor out. That will depend on a wide variety of causes. So whether what we think the tumor is, where it is, what the patient's level of function is. So if the patient's fit, well, and able to have plenty more years that can, then they'll be able to be a good candidate for treatment for chemotherapy and radiation afterwards, or whether this is someone who's more elderly or frail, who would still benefit from some form of radiation, but may not be fit enough for a more larger form of an operation. Also, in regards to tumors, once they've had their operation, we should also think about waiting for them for the results to come back, arranging oncology, so whether they need chemo or radiation afterwards. And then that gives us a chance to look at their steroids, try to reduce their steroids, and try to get them up with a physiotherapist, the occupational therapist, and try to help them recover from the operation point of view. Subarachnoid hemorrhage is our next or another common pathology that we see. We have two main grading systems. So we have the WFNS, the World Federation of Neurosurgery grading scale. It's here on the bottom, so it ranges from 1 to 5, and it all depends on the Glasgow Coma scale, so how the level of consciousness when they came in. And then it's a split into whether they had motor deficits or whether it was present or absent on arrival. We find that the biggest thing about subarachnoid hemorrhage is that they have a rebleeding risk. So it's about 20% in the first 2 weeks, and the mortality of a bleed is about 80%. So very high if they have a rebleed. And all our efforts in regards to the initial management of this subarachnoid hemorrhage is trying to prevent a rebleed. So usually the initial thing is trying to get their blood pressure down under 140, and then figuring out whether surgical or endovascular treatment to try to stop this aneurysm. So the next slide actually tells us a bit about what an aneurysm looks like. So we've got blood vessels in our brain, and you can see an aneurysm is an outpouching of the vessel. And this has the potential to rupture. When it does initially rupture, it can stop, and therefore the next stage is trying to prevent a rebleed. So now the next scale is the Fisher scale. So that's all depending on radiological data. So as you can see, grade 1 is very thin subarachnoid blood. Meanwhile, grade 2, there is thin subarachnoid blood, but there's intraventricular extension. So it extends into the ventricles. And then there's grade 3, which is thick clot that's present. And then grade 4, which is thick with intraventricular extension. And intraventricular extension can be blood within the ventricular system. So you can see right here. So whenever once we've, I guess, initially secured the aneurysm, whether that's through a clip in surgery or whether that's through coils endovascularly, then we think about what are the other complications. So patient can have obstructive hydrocephalus. So now that there's blood in the outside of the brain, the fluid chambers don't drain very well, and that has an increased risk of hydrocephalus, which is enlargement of these ventricles. And that can cause a problem because our skull is an enclosed space. And if there's a lot of pressure, that can cause a patient to herniate and can potentially die. And a treatment for that is putting a drain in. Vasospasm, so because there's blood around the subarachnoid space, it can irritate these vessels and it can cause spasm and can cause stroke. We try to prevent this by starting them on nimodipine. Electrolyte abnormalities, so we monitor their electrolytes regularly, seizures that we monitor for, and they're at a higher risk for thrombosis or clots. Head injuries, so generally if they're admitted under neurosurgery, they're usually categorized as a severe head injury, and Not everyone needs an operation. So sometimes they'll need operation because they need to evacuate a bleed that's causing pressure, or whether they need depressed fractures that needs fixation. Sometimes they need a monitor. So whenever we have diffuse injury or swelling, they need ICU pressure admissions, and they need monitoring in terms of their head injury because they'll be sedated, and thus that may play a role. Or sometimes it's just bleeds or contusions, like especially this one. Well, this one has significant mass effect, but let's say if it didn't have mass effect and they're at a high risk of deterioration, for example, they're on a blood thinner that puts them at a higher risk, then would probably admit them and monitor them under close surveillance. So things to look out for: how their neurology is, how their wounds are they leaking any fluid from their nose or ear? Usually there's some controversial points about prophylactic antibiotics, steroids, and anticonvulsants. Little evidence to really support it. In terms of anticonvulsants, it really depends on case to case. Shunts is another major subcategory. So we put shunts in for many reasons. Whenever we have obstruction to our fluid system, that can cause issues within the brain, in terms of pressure buildup. We can put a tube in from that connects from the ventricles in the head all the way into the abdomen. Some common things are it drains too much fluid, which is called overshunting. The patient can have headaches. They can actually cause subdural bleeds. Undershunting, so that can be due to issues with the shunts itself, disconnections, blockages, and that causes fluid buildup within the brain or infections. And usually, if if the shunt's been placed a long time ago, we try to find out where the infection has come from, whether it's a urine or respiratory or other sources. So for your examination points that we should always look at, so whether there's papilloedema, we look at the eyes to see if there's a lot of pressure that could indicate signs from the brain. Whether there's increased pressure within the brain can cause palsy, cranial nerve palsy, specifically the sixth nerve, upward gaze palsy, and bulging fontanelles. This is more for infants. In terms of checking the shunt for pumping and tapping of the shunts, it's something that senior registrar should be involved with. We always try to compare old imaging of shunts because people with shunts usually have long-standing changes in their ventricles and how big they look. So it's very important to compare how they were before when they were well to how they are now. And sometimes that can be tricky. Shunt series are taking x-rays to make sure there's no disconnections, whether things are appropriately placed. And then once you've done many of the initial investigations, you can talk to your senior about whether doing a shunt study, so tapping a shunt to see if there's any infection, or injecting dye to see the flow of the shunt as well. So those are important things. Next thing is pituitary patients. So we have pituitary tumors. This is misleading because a lot of tumors are actually not cancer. They're actually benign adenomas. But they can cause, whilst they're called benign, they can certainly cause issues. A common access point to the pituitary fossa is through the nose, as you can see. You can go through the sphenoid sinus and into the sella where the pituitary gland lies. So pituitary gland, well, there are two main ways it can cause problems. One is that it grows large enough and it starts to push on other things around. So we've got the optic nerve, the chiasm that runs above. It can cause pressure onto the normal pituitary gland and it can be hormonal deficiencies. It can go out to the sides and cause cavernous sinus involvement. It can cause cranial nerves to the eyes, especially to have palsies, or it can be a functional lesion. So this tumor can secrete hormones on their own. Prolactin, ACTH, growth hormones are the common ones, and they can have symptoms, widespread symptoms, and usually an endocrinologist are closely involved. Whenever we have finished the surgeries, some patients that, initially had low cortisol and needed replacement will definitely need stress dosing because after an operation. And these are some sort of standard guidelines, but of course, usually especially in our institution. We get the endocrinologists that are closely involved and follow up daily on these type of patients. Diabetes insipidus is a complication that can happen. So it's when, because we're disrupting the pituitary gland, and especially a hormone called ADH, there's a higher risk of diabetes insipidus developing. And we try to monitor this by checking their urine closely every hour and this and their input, and making sure that if there's a large amount of volume, maybe 300 mils every hour for th two consecutive hours, it would prompt investigation such as a blood gas to check their sodium to see if they are having diabetes insipidus. We usually have antibiotics because, as you can see, we go through the nose and there's a lot of bacterial flora, and thus, whilst there are ways to prevent it, we do try to put prophylactic antibiotics to prevent the risk of infection. And sometimes leaking from the nose can happen, and when we're concerned if it's brain fluid or not, we can send a sample for beta 2 transferrin to double check. And if it is positive, then notifying a senior to see if there's any CSF diversion techniques, such as putting a lumbar drain in or revision surgeries, is most appropriate. And then finally, we have spine patients. So whenever we have an unstable spine injury, we usually keep the patient flat, strictly mobilizing. The role of steroids is very controversial, with literature not greatly supporting it. And then if they need, surgical fixation for a fracture. So for example, the top picture, the spine is fractured, and thus we can put screws in above and below and stabilize it and allow the body to heal on its own. There are different ways of stabilizing fractures. This is just one method. And it's very important to check with the surgeon or the operation note to see if they were satisfied with the fixation and whether they're happy for the patient to get up and about, or whether they need films to check the position of screws before they get up and about. And that will depend on the confidence of how the surgery went and what was achieved. Other conditions such as stenosis, disc prolapse can be admitted electively, but can be an emergency if they had a sudden change in weakness or pain or any development of new neurology, especially like sphincter or bowel changes as well. We also monitor their wounds. Whenever we do spine surgery, there can be injuries to the lining of the actual spinal cord, and that can cause fluid leak. So that's something that we look out for. And when we think about tumors, we also think about, similar to brain tumors, they can have a role of steroids that can help reduce swelling, and that can be helpful as well. And then the final image just shows a picture about if someone had a fracture and we're not doing an operation for many different reasons, we can put a bracing to keep them in place so that they limit their movement and help the fracture heal on its own. So that concludes main pathologies for how to manage them on a ward-based setting. I think next video we can talk about an EVD and how it's placed and sort of techniques that are used. But until next time, like, subscribe, and chuck in the comments what you want to hear next. I'll see you guys next time.